pathways that are taken by this. We are mainly looking at the pathway that is taken by these electrical activities. So by the way, these electrical activities, they're just similar to the electrical activities that occur in the conductors, in wirings, and the like in the usual electrical circuits that we know. And the conduction system of the heart is also similar to the wirings that we know in the usual circuits. So the conduction system of the heart is the pathway over which electrical activity occurs. The electrical activity in the heart is initiated in specialized cells called pacemakers, right? So it begins in the pacemakers. When we go into the usual circuits, the circuits that consist of the wires and the resistors that you all know about, the electrical activity begins in a cell or in a power source, right? So in the heart, the electrical activity is initiated by special cells called pacemakers. There are generally 4 types of pacemakers in the heart. We have the SA node, which is also called the sinoatrial node. Then we have the AV node, atrioventricular node. We have the bundle of His and the Purkinje fibers. So these pacemakers, they have the ability to initiate electrical activity. In a normal situation, only one pacemaker should initiate, which is the SA node. But in cases of pathology, the SA node may fail and any of the other should now initiate. But the sequence in which this occurs is that when the SA node fails, the AV node is the next to initiate. If it also fails, then the next to initiate is the bundle of His, and the last is the Purkinje fibers. So all pacemakers, they also have the ability to transmit electrical activity. So by this, I mean, let's say the electrical activity was initiated in the SA node, then in the AV node, it's no longer a initiation, it's now transmission. So that's what we mean by the last point. So the pacemakers, they have the ability to initiate and also to act as transmitters. Right, I'm trying to go to the next slide. Right, this is my next slide. This slide is actually showing the system, the conduction system of the heart. The 4 initiators are also shown. The first one being the SA node, which is located in the right atria. Hello, can you hear me?
Go ahead. Yes, we can hear you.
Okay. Then the next node to talk about is the AV node, which is this one. Then the next pacemaker is the bundle of His, which is just next to the SA node. Then from the bundle of His, there are some conductors that you can take note of, which are the left bundle branch and the right bundle branch. So from the bundle of His, the activity goes to the right bundle branch and the left bundle branch. Then it reaches the Purkinje fibers, which are these fibers at the end of, or at the apex point of the heart. Right, now let's move to the next slide. Now let's talk about ECG Length. So when we're talking about ECG Length, an ECG Length is a graphical representation of the electrical activity of that. So the transmission and the generation of these electrical activities can actually be pictured or can actually be produced in a graphical form. So when we do that, now we are in the clinical area. When we do that, when we're producing these graphs of the electrical activity as it moves from the SA nodes to the AV node, through the bundle of V's to the last point to the Purkinje fibers, when we're producing those graphs, we are producing what we call the ECG leads. So generally, an ECG lead is a graph of voltage on the vertical axis versus time on the horizontal axis. So the voltage is generally measured in millivolts. So the ECG paper, if you take a look at the ECG paper, it consists of large boxes and small boxes. So each box vertically, it represents a certain number of millivolts. The smallest box, actually, it's 0.1 millivolts. Sometimes the millivolts or the vertical axis can mean the amplitude of this voltage. So when we talk about amplitude, we now denote it as 1 millimeter. So each small box means 1 millimeter when we're talking about amplitude on the vertical axis. Now, when we go to the horizontal axis, these are the time axis. It represents the time on the graph. So the time, when we are looking into the small box, each small box will represent a time frame of 0.04 seconds. So that's generally the standard ECG paper. Okay, now let's move to the next slide. Right, the next slide is showing a pictorial view of the LEDs, ECG LEDs. So when we spoke of the ECG LEDs as the graphical representation of electrical activity, you can look into the heart at different views or at different planes or at different directions. So when you do that, you produce different or a multiple or a number of LEDs. So there are generally 12 standard LEDs, but they can go up to 15. But generally in the clinical area, the standard is 12 or 12 directions. So we have LED 1, 2, 3. Then we also have the AVF, AVL, AVR. Then we have V1 to V6. So the first 6, which is LED 1 to 3 and AVF, AVL, AVR, these ones, they are in the direction or they lie in the coronal plane as shown in this diagram. So LED 2, for example, is a graphical representation of electrical activity along this line, which is along the major axis of the heart. That's why in most cases, when you view an ECG paper, you see a LED 2 at the bottom. Why they choose it? Because it views the heart in the longitudinal axis, just like we do in echo when we image the heart in 2D. We like that plane because it shows a lot. We make it is actually chosen as a standard for imaging the heart in the longitudinal axis. So that's the same plane in which the major or in which you can acquire more information about the heart, about the electrical activity. And in this LED, usually you can actually pick whether the ECG has got certain properties or has no properties. Unlike in other LEDs, you cannot determine such as some of the properties that you can determine on LED 2. So that's why it's usually chosen as the standard. for making all the calculations that you see on the ECG paper. Okay, then the other leads V1 to V6, they are in the axial plane. As you can see, they are in the axial plane, and V1 is in this direction, V2 is in that direction, V6 is viewing the heart or imaging electrical activity in that direction. So now each of these ones can actually tell you what is happening when you look at the heart in a certain direction. For example, suppose there is infarct in the inferior part of the heart. So the inferior part, we have to assess it by assessing lead 2. If you look at the table beside the diagram, lead 2 assesses the inferior part, lead 3 is a direction which views the inferior part, and AVF the inferior part. So if the inferior part, suppose there is an infarction, you have to assess this specific leads if you suspect an infection in the inferior part of the heart. So the same thing in the anterior, in the septal, if you are suspecting a specific event of the heart or of myocardial pathology in the septal region on an ECG, you have to assess your V1 and V2. But if you want to generally have an overall look of the heart and do your measurements, all those measurements that you see, I'm not gonna talk about them in this presentation. That will require another presentation. All those measurements, you have to assess lead 2 because it's the one that is standard, that is chosen as standard. You cannot go to assess on lead V6 because you will miss some other information. All right. So that's the slide on ECG Length. Now let's move to the other slide, which talks about the components of an ECG Length. So now we want to look at the components of this graph. Why do we want to look at the components? Because you will see how we then apply this information to echocardiography. You have to know what each component represents in terms of activity of the heart. So generally we have 4 types of components, or there are 4 types of components that make an ECG. There are waves. Waves are just upward and downward electrical deflections. They represent depolarization or repolarization. So the waves, they include the P, the Q, the R, the S, and the T. That's why the lead is usually referred to, or in ECG, the PQRST graph, or PQRST wave. Right, we also have the complex. We have one complex in all the ECG leads. So a complex is simply a combination of waves. Right, a one wave to the next without any zero electrical activity. I'm sure this point I will explain it when you see the graph on the next slide. So when we talk of combination of waves, the waves should follow each other without any break in activity of depolarization or repolarization. So we have one complex, the QRS complex, which consists of the Q, the R, and the S wave. Then we have what we call a segment. It's a period of no electrical activity. So if there's no electrical activity, it means the ECG line will be just flat, what is usually referred to as isoelectric line. So these include the PR segment and ST segment. Right, so the PR is the segment which is between the P wave and R wave. We also have intervals, right? Intervals are combination of a wave and the segment. We have the PR interval, QT interval, and RR interval. Now let's move on to the next slide, which is a pictorial view of the ECG length. So this is what I was talking about. This is the wave. This one is an upward deflection. So this one we call it a wave. It's the P. Then the next wave is the Q, which is a downward deflection, starting here, ending here. Then starting here, going to up to this point and up to this point, that's the R wave. So this is what I was talking about when I was saying a complex should be a continuation of waves, different waves, without any gap like in this point. So we have Q, there is no gap between Q and R, it's just a continuation. Then we have S, so this one is a complex, QRS complex. Then we have a gap, so we have a T. So we cannot have ST complex, or we cannot have RST complex because there is now a gap between these two waves. So generally, that's what a complex is. This one is a segment because it consists of no activity. Then it lies in the isoelectric line. Right, the PR segment, which is this segment, is usually used as the standard to determine if the other segments lie in the isoelectric line. Because there are some a certain pathology whereby the ST segment usually can be elevated for starting here and going up to this point, starting here, going up to this point. So this one will be called a depression or ST depression. It usually represents a certain pathology, right? So I'm not going to talk a lot about that. So how do you know whether the ST is the one that is in the isoelectric or the PR is the one that is in the isoelectric? Just keep in mind that the PR is the one that is usually used as the standard to determine whether ST is in the elevated or depressed state. Now let's move on to the next slide. Right, the next slide is taking us to applications of ECG in echocardiography. Right, in echocardiography, we deal with very, very small measurements. Right, this means a small error in a particular measured parameter can result in a remarkable misdiagnosis. So how can we avoid making these errors? Then we have to borrow ECG to echo or borrow ECG to synchronize it in an ultrasound scan machine. That's when the application of ECG comes in. So to avoid this, measured parameters should be precisely determined to avoid this misdiagnosis. Since some of the crucial measurements in echo are done at specific cardiac events like the left ventricular end diastole and left ventricular end systole, ECG synchronized with echo can be very, very helpful in avoiding making these small errors. So moreover, the ECG can be used in determining the heart rate for cardiac output calculations. So in an ECG, you can calculate the heart rate. Usually it's one of the best way of calculating or having an accurate heart rate of a certain individual. So now ECG is used to enhance or to lessen the amount of errors in echo calculations. So that's its main application. All right, let's go to the next slide. When measuring the left ventricle on echo, we are measuring mechanical activity and not electrical activity as measured on ECG. The electrical and mechanical activity do not occur simultaneously. So what does this mean? Let's go back to the diagram. right? In this diagram, sorry, I forgot to talk about what each wave represents. We have the PQRST wave. So this wave, the P wave, it represents atrial contraction. So this is atrial contraction, the P wave. The QRS complex is ventricular contraction or ventricular depolarization. Where it starts, it's where we are saying start of the contraction, and where it ends as end of contraction, which is end systolic event. So end systolic event, that's when we make most of our echo measurements. Then the T wave, it represents a relaxation, but now this relaxation is active relaxation. Active relaxation. Then the ST segment represents relaxation, but this is passive relaxation. So this, from this point to this point, the heart is relaxing. So this is end diastole of the ventricle, right? The end of T is end diastole. So now going back to the applications of echo. Applications of ECG in echo. For example, we want to measure the ejection fraction of a particular individual. We have to take a certain measurements at certain cardiac events. We have to take the measurements, the maximum diameter of the left ventricle in diastole and the minimum diameter of the left ventricle in systole for us to calculate ejection fraction. I'm not going to talk about ejection fraction, but it's a very, very useful measurement in echo. It can diagnose a lot of conditions. So this measurement is crucial. So now to get an exact frame of end diastole and end systole, we have to go to the ECG tracing that is synchronized to the echo image. So now people may wonder, why do you want to measure this this ejection fraction on a 2D picture? Why can't you use M mode? We know that we have some challenges. All these methods, they all have pitfalls. Even this 2D image, it has also its shortcomings, but it has also its strengths. So when it comes to determining the ventricular dimensions, 2D is a greater strength than M mode. Why? Because the M mode cases sometimes cannot be aligned at 90. I'm sure people who practice echo, they agree with me. It's not always in all patients that you can align it at 90 to the IVC and to the posterior wall here. So in such a case, you can then apply this technique of synchronizing with the ECG strip, right? So at the bottom of this image, we have the ECG tracing, right? If you look here, there is a small red dot. This small red dot, unfortunately, I couldn't make this one a video so that you can see how I did the measurements. This small dots, if you pause the image, the 2D image, let's say you've done your correct plane, you pause on the ultrasound or you freeze, then you can move by the kidney pattern. Using the kidney pattern, you can move the frames. I'm sure you all understand what I'm trying to put across. You can move the frames backward and forward to determine the longest diameter or the shortest diameter that you want to measure. But as you move, this red dot also moves. So this red dot can then go and tell you that at this point, this is a certain cardiac event. So when I went back to the slides to show you that at the end of the QRS complex, that's the end systole. This means that at end systole, I am supposed to measure the end systolic diameter. But because I said these events, they do not occur simultaneously. It's the other way around when you are dealing with an ECG synchronized to ultrasound. You will find that at the end of, you'll find that at the end of diastole, this dot here, at the end, it's at the end of diastole. It's actually on ECG synchronized with echo. It's actually end systole, because the other event, it takes some time, or the mechanical event takes some time. When the heart contracts, by the time the ECG is detected by the machines, it's actually now the next phase, which means that on ECG, if you want to take a frame for end diastole, you have to go on ECG, you have to go on end systole. If you want end diastole on ECG, go to end systole. If you want end systole on ECG, go to end diastole. So for example, this red dot is lying at the end diastole on the ECG, but on the frame, it will be end systole, that is the minimum diameter. So on this frame, if I'm here, if the red dot is here, I am measuring this distance, number one. If I am here on ECG, this is end systole. But on the frame for the B mode, I am actually in the greatest diameter, which is a measurement which was done. This measurement is not actually in this frame. It's superimposed on the other frame. Sorry for that. I couldn't do two images separately. So this is superimposed. So this zero distance was actually measuring the greatest diameter of the left ventricle. So that is the small trick on synchronized ECG on echo. So with that in mind, it means our EF or our ejection fraction will be a better value, because we synchronized our measurements with the ECG. We got the smallest diameter. We got the largest diameter of the left ventricle. So that will be a better value than just doing it without the ECG tracing. Right, this is an image of the left ventricle, M-mode image, trying to illustrate that, as you can see, this cursor line is not at 90 degrees to the IVC, sorry, to the intraventricular septum and the posterior wall of the left ventricle here. Because of that, someone can be tempted, because the M-mode picture looks like, you can be tempted to come and make your measurements here and say, I've measured it nicely because the M-mode looks nice. But in reality, this is not 90. You are overestimating the calculations. So what I was talking about, let's go to the PQRS complex. You see, this point is the greatest point where we would take end diastolic diameter. In this point, you see it's exactly at the end of the PQRS. Is at the end of QRS complex. QRS complex is contraction. It represents contraction, which is supposed to be end systole. So that's the vice versa that I was talking about in the ECG. You should take note of that. ECG, which is synchronized to ultrasound. This point represents end contraction of the ventricle. But when you are measuring here, it's superimposed on the frame or in the line of end diastole. If you come to end systole, this is supposed to be end systole. Unfortunately, the end of the T wave here is not clear, but it's supposed to be here. It's end diastole here on ECG, but on echo, it's end systole. So that's the vice versa. Please take note of that if you are going to be using ECG synchronized to echo. So this picture, the general image, the ultrasound image, is trying to illustrate that it's nice, looks nice. Think, no, I've got the picture, but go back to your case, it's not 90. So you better do a 2D image calculation, which is this one, to be better compared to this one. So here you're overestimating, and here you're close. It may not even be correct, but you are close, better than this picture. Right. The same application is also using measuring this rate. The last measurement I did was measurement number. This was the last measurement. So the last measurement was at the end of the T wave, which is at the end relaxation. So at the end of relaxation of the deep trace, which means on echo picture we are at the end systole. So this was supposed to be the measurement corresponding to this plot. Then when this measurement was done, this red dot was here at end systole on ECG. Then on the ultrasound, it was measuring end diastole. Right, these are my references. I think this is the end of the presentation for today. Thank you.
Thank you, Mr. Tawanda, for that lovely presentation.
Thank you.
Are there any comments, any additions, any questions from the audience? Feel free. Anyone with a question for Mr. Tawanda? Yes, go ahead, Mr. Gesh.
Yeah, thank you so much, Mr. Tawanda, for the wonderful presentation. My question comes to when it comes to placement of the leads on the patient. For example, you interchange the leads. For example, the right lead goes to the left lead. Is there an effect on the results when performing ECG, when interchange the leads?
Mr. Gesh, would you repeat your question?
Yeah, I'm saying when you're examining a patient using ECG, for example, you interchange the leads.
Yes.
Let's say you put the leads that's supposed to go on the right arm goes to the left arm. So is there an effect when you interchange the leads concerning where the results, concerning results? Is it clear now?
It is. Mr. Tawanda seems to have left the building. Okay, let me just, I'll get back to you. Is there someone in the audience that can answer that question?
There's a hand from Mr. Nchete.
Mr. Nchete, yes, go ahead.
Hello.
Hello, go ahead.
You
Good
can
evening.
get me. Good evening. I wanted to answer Mr. Gesh's question.
Yes, please. Let's go ahead.
Yeah. Of course, once you change your leads, you expect the results not to be the way you expect them. Some machines, the way they have been designed in a way such that if you put your right lead on the left lead, on the left limb, it will actually even signify you to say wrong lead placement. I don't know about some other machines, but the machines which I've used so far, that's the function, and believe me, it will affect your results. I hope I've answered your question.
Yes, sir, you have.
Okay, thank you.
Mr.
Thank you
Manatsa
so
is
much.
back. Sorry,
Oh, he's
Mr.
back,
Manatsa
okay.
is, yes, he's back.
Mr. Tawanda, can you hear me?
Yes, sorry, I'm having some
Technical problems.
Yes, hello. Can I get
Uh,
the question again? I'm sorry I didn't hear it properly because of connection problem.
The question has been answered, but Gesh, do you want to just ask him again? Because he might just give you, clarify
Yes,
as well.
yeah, he might add some more points.
Yeah.
My question was, for example, examining the patient using ECG, then you, when placing the leads, for example, the ones that's supposed to go to the right goes to the left and vice versa. So is there an effect on the results? That's a question.
Hello?
Yes. Mr. Tawanda, can you hear us?
Yes, yes, definitely. If you vice versa the lead placement, you sometimes may not even get the tracing. The results will be different. Definitely, because each lead they are supposed to be specific for us to get specific graphs. So, but for ECG synchronized to ultrasound, usually it's just 3 leads which are just simple to follow. But for the other ECG, the 12 lead ECG that produces 12 tracings, that one you have to be more specific in placing your leads. Otherwise, you get false results.
Thank you so much, sir.
Does that answer your question, Mr. Gesh, Larry?
Thank you. Yeah, yes.
Okay, thank you. Mr. Silav, Mr. Richard, you can go ahead.
Yeah, I just wanted to add on what Mr. Tawanda just mentioned. Normally, when you place the ECG lead, you misplace them. You put the right to the left, or maybe the one which is supposed to be on the lower limb, you put it on the upper limb. You find that when you are recording the recording, there will be misrepresentation, or even the significant diagnostic, like for example, errors that will come like instead of recognizing the proper areas, you find that maybe you recognize the anterior infarction, anteroseptal infarction. In short, you can misdiagnose the whole thing if you misplace you misplace the electrode. You give the wrong diagnosis altogether. So the electrode needs to be placed correctly for you to have the significant diagnostic result.
Thank you so much, Mr. Richard.
All right.
Any other questions? Any questions, any additions? Yes, Mr. Gesh, do you have another question?
Yes, please.
Yeah, go ahead.
Yeah. Most of the machines that I've used when doing ECG, they also come up with their diagnosis. It is written there on top, like the machine coming up with a diagnosis. So my question is, how reliable are those diagnoses that the machine gives out? Of course, there's a caution there that says this is machine-based. So an operator is also at liberty to make their own diagnosis. So I'm asking from the experts, how reliable are those diagnostics that the machine produces?
Ma'am, what is
Mr.
adenomyosis?
Mr. Tawanda, did you get the question?
What is adenomyosis?
Anyone in the audience that wants to answer the question, or Mr. Tawanda, if you want to go ahead?
Ma'am, what is adenomyosis?
Mr. Chete wants to comment, I think.
Mr.
Hello?
Chete, you're most welcome. Yeah, go ahead.
Okay, yeah, thank you very much. I wanted to respond to Mr. Gesh's question. Yeah, it is true. Most of these machines, they come with, they have been set up already at the point of manufacturing. However, we need to realize that some of these machines, most of them, they come from Western countries, and they have got their own standards and protocols. Sometimes you find that you're doing an ECG on someone who's 16 years old and maybe less than that, and it will give you to say, based on pediatric, the information which you fed the machine, it's normal. However, we can't basically rely on these results. That's why it's important, even if the result is normal, it's important to refer to the referring cardiologist so that they can take time and read. Sometimes you find that even these, we have talked about the intervals, QRS, and all those things. You find that there's prolonged maybe a certain interval is prolonged, then there it will just say due to prolonged this interval. You don't know what is contributing to that. So my answer is we can't rely on these. It's better you send to referring cardiologists so that they take time and go through your ECG interpretation report. Again, at the same time, it depends with the person who's doing the ECG. You know, lead placement sometimes, you know, you're supposed to put, for example, V1, V2, you're supposed to put them in intercostal space, which is 4 thoracic. But you find that maybe someone who hasn't been doing ECG for a long time, instead of putting them in the right place, they put them somewhere else. And that will compromise the results. So the best way is once you do an ECG, don't just rely on those results which are interpreted by machine. It's better take them to the referring cardiologist so that they can take time as well, go through the results. Thank you.
Thank you so much, sir. My question is answered.
Did we lose Mr. Nchete?
Yeah, I think so, but he finished giving the
Okay.
answer.
But okay, that's okay. Any other questions? Any additions? I have a question for you, Mr. Gesh.
Yes.
When you are doing you take your ECG measurements, for instance, do you take that printout to any one of the doctors to be able to look at it and be able to ascertain whether the readings are correct or not?
Yes, they do.
What's the practice of the ground?
After printing out,
Mm-hmm.
yeah, the results are reviewed by the doctor, the referring clinician.
Okay.
That's a procedure.
Okay, fair enough.
Thank you.
Any other questions, any additions before we close the meeting? Our speaker has been logged out. Unfortunately, a lot of people are having problems with network tonight. So I'm just going to close the meeting unless anyone has got any last minute contributions. But I just want to appreciate everyone that logged into this meeting tonight. I hope you learned something. I'm going to share the presentation on our platforms, the ultrasound platform plus the RSZ platform. And then this particular presentation will be shared on YouTube. So if there's anyone that missed the presentation, maybe because they logged in late, you can access it on YouTube. But thank you so much for the lovely presentation from Mr. Tawanda. Thank you for the contribution, Mr. Gersh and Mr. Nchete, although he's not here. But thank you for making time for the meeting. So I'm just going to wish you all the best for the rest of the week. Stay safe out there. My name is Atupele. I'm the Secretary General for Radiology Without Borders. If anyone has got any questions, my number is on the platform. You can always inbox me. But for tonight, I'm just going to close the meeting. With the next presentation most likely will be in 2 weeks' time. We're going to share that information and we'll let you know. So good night to everyone.